The following presentation introduces and provides details regarding music's roadmap for management of men with favorable risk prostate cancer. Among other factors, the motivation for developing this roadmap stems from the wide variation in use of active surveillance identified among men in Michigan with favorable risk prostate cancer. As you can see in this figure, for men with low-volume Gleason 6 cancers, rates of initial active surveillance range from 0 to 100% across urologists in the state. In addition to the wide variation in use of initial surveillance, data from the music registry also revealed that many men who enter surveillance are not receiving follow-up testing consistent with best available guidelines. For example, nearly 50% of patients undergoing active surveillance as primary treatment had fewer follow-up biopsies than what is recommended by guidelines from the National Comprehensive Cancer Network. In this context, we see two specific opportunities where the music roadmap can help us make progress toward our goal of making Michigan the best place in the world for prostate cancer care. First, although some differences in practice patterns will always be present, we see an opportunity to decrease the statewide variation in use of initial active surveillance among men with favorable risk prostate cancer. After all, it probably doesn't make sense that depending on which urologist he sees, a man with low volume Gleason 6 cancer has a likelihood of being managed with active surveillance that ranges from 0 to 100%. Second, we see a need to increase the consistency of follow-up testing for men that enter surveillance, thereby ensuring the early identification of patients who should transition to local therapy. Let's take a deeper look at the content of this roadmap. The overarching goal of developing and disseminating this document is to provide urologists with pragmatic guidance in the clinic for determining who should consider active surveillance and steps for how to implement surveillance as a primary management strategy. One key consideration is that the roadmap is intended for use among men diagnosed with favorable risk prostate cancer. In music, we define this group of patients as all men with early-stage Gleason 6 cancers and a subgroup of men with low-volume Gleason 3+4/7 cancers. The roadmap is not intended for use among men with higher grade and or higher volume early-stage cancers for whom initial local therapy is usually indicated. One important feature of the roadmap is that it defines two distinct phases for active surveillance. First is the consideration phase that involves 4 specific steps to take while considering patients for active surveillance. Step 1, estimate life expectancy, and more specifically, whether a patient's estimated life expectancy exceeds 10 years. For patients with an estimated life expectancy less than 10 years, watchful waiting is often appropriate. Conversely, for patients with an estimated life expectancy greater than 10 years, we proceed to the next step in considering active surveillance versus local therapy. Step 2, determine the appropriateness of active surveillance for an individual patient based on established criteria from a music consensus panel. Step 3, obtain one or more confirmatory tests aimed at improving risk stratification for individual patients. And Step 4 involves using the information from Steps 1, 2, and 3 to support purposeful, shared decision-making with our patients about proceeding with active surveillance versus local therapy. The second phase, defined in this roadmap, is the surveillance phase. This phase focuses on the actual implementation of active surveillance and includes 3 specific steps. Step 1, partner with our patients in the selection of a specific surveillance plan. Step 2 involves longitudinal monitoring with follow-up clinical exams, PSA testing, and tumor burden reassessments. Step 3 involves iterative consideration of the need for transition from surveillance to local therapy based on results of follow-up testing and evolving patient preferences. Now let's examine the consideration phase in more detail. Again, this phase involves the 4 sequential steps highlighted in this figure. Step 1, estimate life expectancy. Step 2, determine the appropriateness for active surveillance. Step 3, obtain confirmatory testing. And Step 4, engage in shared decision-making with the patient. During development of the roadmap, music urologists encouraged the identification of pragmatic tools for estimating life expectancy. Accordingly, the roadmap suggests 3 tools that can be used in the clinic, including a comorbid condition checklist, life expectancy tables from the Social Security Administration, and a calculator for estimating the risk of death from other causes among men with prostate cancer that was developed at Memorial Sloan Kettering Cancer Center. Let's look in a bit more detail at the comorbid condition checklist. This was developed for the roadmap by adapting a similar tool published in 2013 by Cho and colleagues in the Annals of Internal Medicine. Our perspective is that this checklist represents the most pragmatic tool for use in a busy clinic. As illustrated in this slide, the checklist involves 3 explicit steps that yield for an individual patient the age at which their life expectancy will be less than 10 years. The first step is to identify a patient's specific comorbidities from the 14 conditions included in this checklist. Individual comorbidities are assigned a score ranging from 0 to 5 based on severity. Next, in Step 2, points for the individual conditions are summed to determine the comorbidity grouping for an individual patient. For example, patients with none of the 14 conditions are assigned into the no comorbidity group. In contrast, patients with conditions that sum to a score of 5 or higher are assigned to the high comorbidity group. Step 3 then involves using the comorbidity group assignment to determine a specific age at which life expectancy is estimated to be less than 10 years. For instance, white men in the no comorbidity group will have an estimated life expectancy less than 10 years at age 80. In contrast, white men whose comorbidity profile places them in the high comorbidity group have an estimated life expectancy less than 10 years at age 66. Next, for men with an estimated life expectancy that exceeds 10 years, the second step in consideration phase involves determining the appropriateness of active surveillance for an individual based on the established criteria developed and published in the Journal of Urology by a consensus panel of music urologists. As you recall, the consensus panel, led by Michael Scher from Wayne State University and Brian Lane from Spectrum Health, developed the recommendations for the appropriateness of active surveillance for 160 different patient scenarios based on specific clinical characteristics, including tumor grade and volume, PSA density, race, life expectancy, and a patient's sexual interest and function. A summary of recommendations from the group is provided in this table. As you can see, colleagues from across the state recommended that active surveillance be considered or strongly considered for all men with low or intermediate volume Gleason 6 cancer on the diagnostic biopsy. The distinctions between the recommendations to strongly consider versus consider surveillance were based on differences in tumor volume, PSA density, race, life expectancy, and sexual function and interest. For patients with high volume Gleason 6 or low volume Gleason 3+4/7 cancers, the consensus panel offered a recommendation to consider surveillance for some patients based on race, life expectancy, and other factors. For other scenarios, however, the panel offered a recommendation of uncertain, indicating a lack of consensus around the appropriateness of surveillance. This slide presents a more complex summary table that is included in the printed and electronic versions of the roadmap. This table provides clinicians and patients with the panel's specific recommendation for each of the 160 distinct clinical scenarios. As you review this table, it is worth noting that within several of the tumor grade and volume categories, recommendations from the consensus panel differed according to other relevant patient factors, including race, life expectancy, and sexual function and interest. The consensus panel also made suggestions as to the terminology one might use in counseling patients within each appropriateness category. The counseling statements seen here for each grouping were designed to indicate the panel's level of comfort in recommending the use of active surveillance for specific scenarios. These statements or similar language can be used in the clinic when discussing the panel's findings with individual men considering surveillance. Now let's turn to the third step of the consideration phase, performing one or more confirmatory tests aimed at improving risk stratification for men with favorable risk prostate cancer who are identified as appropriate candidates for active surveillance. In many ways, this represents a new and important step in the care of patients considering surveillance as a management option. The goal of this step is to perform an additional test or tests that provide reassurance that we are not missing a higher grade or higher volume cancer that would be better managed with initial local therapy. Based on feedback from music urologists, the roadmap identifies 3 different confirmatory testing strategies. These include repeat prostate biopsy, multiparametric prostate MRI, and/or genomic testing on tumor from the original biopsy specimen. These tests may be used individually or collectively based on provider and patient preferences. The roadmap recommends that one or more of these tests be performed within 6 months of the diagnosis. Let's first consider repeat biopsy as a confirmatory test. The roadmap offers specific recommendations that confirmatory biopsy in men considering surveillance should include at least 12 cores, with consideration given to sampling of the anterior prostate gland and/or saturation biopsy techniques. Again, the goal is to reduce the possibility that an existing higher grade and/or higher volume cancer was not sampled on the original biopsy. For repeat biopsy, we define a reassuring test as biopsy findings where the tumor grade and volume remain consistent with the active surveillance appropriateness criteria. In other words, if a patient with an intermediate volume of Gleason 6 cancer on the first biopsy also has only intermediate volume Gleason 6 cancer on a follow-up biopsy, the biopsy result would be considered reassuring. On the other hand, an example of a non-reassuring test result would be when a patient had only Gleason 6 cancer identified in the initial biopsy, but had 4 cores with Gleason 7 cancer identified on repeat biopsy. In that scenario, the roadmap recommends proceeding to the shared decision-making to more strongly consider local treatment. Prostate MRI represents a second confirmatory testing strategy. There are, however, several steps that must be taken to ensure its optimal use. First, the roadmap recommends performing confirmatory MRIs between 6 weeks and 6 months after the original diagnostic biopsy. If the study is performed before 6 weeks, there is a possibility for significant biopsy artifact that may preclude identification of higher grade cancers. Second, it is essential that the radiologist interpreting the study has appropriate expertise with multiparametric prostate MRI Third, technical specifications for the MRI should include a 3 Tesla magnet, appropriate sequences, and multiparametric imaging. Fourth, the MRI report should characterize lesions based on the PIRADS version 2 classification system. For patients undergoing MRI as a confirmatory test, the absence of a PIRADS 4 or 5 lesion can be considered a reassuring result. The presence of a PIRADS 4 or 5 lesion indicates a significant risk of Gleason 7 or higher cancer and should prompt repeat biopsy. During the repeat biopsy, targeted cores should be obtained from the region of interest, and further systematic prostate sampling should also be considered. Subsequently, the roadmap recommends proceeding to shared decision-making to consider more strongly local therapy. One point of clarification related to MRI: if an appropriately obtained MRI is ordered prior to diagnostic biopsy, and the diagnosis of prostate cancer is made based on a post-MRI biopsy, then the combination of MRI and biopsy would fulfill the recommendation for confirmatory testing. Genomics represents the third category of confirmatory tests specified in the roadmap. There are several commercially available genomics tests that can be performed on tumor identified in the original prostate biopsy. The availability of these tests is contingent on collaboration with your pathologist. The roadmap considers 3 specific genomic tests. The Prolaris test provides an estimate of prostate cancer-specific mortality based on genetic material in the tumor identified in the patient's biopsy specimen. We define a reassuring Prolaris test result as a 10-year estimate of prostate cancer-specific mortality less than 3%. For the Oncotype DX test, the roadmap defines a reassuring test result as greater than 80% freedom from primary pattern 4 cancer. Likewise, a Decipher score of less than 0.2 is also considered reassuring. For patients whose confirmatory genomics tests yields a non-reassuring result, the roadmap recommends additional shared decision-making to more strongly consider definitive treatment. Finally, after estimating life expectancy, establishing the appropriateness of active surveillance, and obtaining and interpreting the results from one or more confirmatory tests, we recommend reconsidering with each individual patient the merits of proceeding with active surveillance versus definitive local therapy. This concludes our coverage of the consideration phase outlined in the roadmap, and we now turn to the surveillance phase. Following completion of the consideration phase, a patient will select either active surveillance or local therapy as primary management for his prostate cancer. Patients selecting active surveillance will enter the surveillance phase, a period that involves longitudinal monitoring for changes in cancer risk and/or patient preferences. The components of this phase include regular clinical evaluations, follow-up PSA testing, and repeat tumor burden reassessments with prostate biopsy and/or MRI. Let's look at the surveillance phase in a bit more detail. Like the consideration phase, the surveillance phase is divided into several sequential steps. Step 1 consists of selecting a specific surveillance plan from 2 recommended options, a high-intensity monitoring plan and a lower-intensity monitoring plan. Step 2 involves longitudinal monitoring for changes in cancer risk and/or patient preferences. Step 3 involves assessment of the need for transition to other treatments based on new clinical information obtained during the surveillance process. Again, the first step in this phase involves selecting a specific surveillance plan that outlines for both the urologist and the patient an anticipated schedule for follow-up testing. As you will see, the roadmap outlines high-intensity and low-intensity surveillance plans that differ in the frequency of follow-up PSA testing, digital rectal examinations, and tumor burden reassessments. The options for tumor burden reassessment include repeat prostate biopsy and/or a multiparametric MRI. We recommend discussing with individual patients the relative trade-offs of higher versus lower intensity follow-up in the context of both his cancer and his preferences. This conversation will result in selection of the initial surveillance plan, recognizing that this may evolve over time for individual patients. The roadmap's high-intensity surveillance plan recommends biannual PSA testing and digital rectal exams, along with annual tumor burden reassessments with prostate biopsy and/or multiparametric prostate MRI. In the absence of a transition to local treatment, this follow-up plan is continued until the patient's life expectancy is estimated to be less than 10 years, or until a patient and his urologist decide lower intensity follow-up is warranted for another reason. We should also point out an important caveat related to tumor burden reassessments during the surveillance phase. Although the roadmap identifies prostate MRI as a tool for tumor burden reassessment, we also recommend for most patients MRI should not be used in isolation. A general recommendation is that a prostate biopsy should be performed at least every other time a patient is due for tumor burden reassessment. Finally, individual urologists and their patients are best positioned to make personalized decisions about whether to use surveillance biopsies alone or a combination of prostate biopsy and multiparametric prostate MRI for tumor burden reassessments during the surveillance phase. In contrast to the high-intensity plan, the roadmap's low-intensity surveillance plan recommends annual PSA testing and digital rectal exams. Tumor burden reassessments are recommended at least once every 3 years. In the absence of a transition to local treatment, this cadence of testing is continued until the patient's life expectancy is estimated to be less than 10 years, or until a urologist and the patient decide that a different follow-up plan is warranted. Step 2 of the surveillance phase involves longitudinal monitoring for changes in cancer risk and/or patient preferences. Working together, urologists and patients follow the selected surveillance plan, obtaining and interpreting information from clinical evaluations and follow-up testing. New clinical information obtained during this step may necessitate additional evaluations beyond those outlined in the specific surveillance plan, and may also prompt reconsideration of the merits of continued surveillance versus other treatments. During the period of longitudinal disease monitoring, there are several specific scenarios that should prompt further evaluation, including, for instance, new and concerning digital rectal exam findings and rapid PSA doubling times. In these scenarios, the roadmap recommends proceeding with repeat biopsy and/or multiparametric prostate MRI, even if it is at a shorter interval than called for by the surveillance plan. During the surveillance phase, longitudinal evaluation may identify higher risk cancer that was not evident during the consideration phase, making it appropriate to strongly consider a transition to local therapy. Thus, the third component of the surveillance phase involves assessing the need for transition to other treatments based on new clinical information obtained during follow-up. Specific findings that should prompt a discussion regarding transition to local treatment include the following. If a surveillance biopsy demonstrates progression of tumor burden to a higher risk category, such as a greater volume of Gleason 3+4 cancer or predominance of Gleason pattern 4 cancer. If an MRI performed for tumor burden reassessment identifies a new PIRADS 4 or 5 lesion or a significant change to a previously identified lesion, either a repeated targeted biopsy or transition to local treatment is indicated. If follow-up genomics testing indicates reclassification into a higher risk category, consideration of a transition to local therapy is also indicated. Finally, patient preferences may evolve over time. Even in the setting of stable clinical tumor characteristics, some patients will request a transition to local therapy. In this scenario, such a transition is often reasonable, but urologists should once again engage in shared decision-making to more fully understand the patient's priorities and his preferences. This concludes our discussion of the MUSIC roadmap for management of men with favorable risk prostate cancer. This information will be available to all MUSIC urologists and practices in several formats, including an easy-to-use flip chart for clinic rooms and an electronic version that can be downloaded from the MUSIC website at musicurology.com. While the roadmap is one important tool for urologists and other providers caring for men with favorable risk prostate cancer, MUSIC has also developed several other tools to support our efforts aimed at optimizing the care provided for these patients across the state of Michigan. Recognizing that it is essential for patients to understand the rationale and process of surveillance, we developed patient-specific educational materials and calendars that outline the indications for surveillance and the timing and process of follow-up testing. These materials will soon be distributed to all MUSIC practices and can be shared with men considering active surveillance. In addition, we are leveraging the MUSIC registry to develop a new electronic system for notifying data abstractors about patients who are classified as being on surveillance but have no follow-up test results entered in the registry over an 18-month period. This will allow practices to contact these men and arrange for appropriate evaluations. Finally, in order to hold ourselves accountable for improvement in this area, MUSIC has developed 4 quality measures for active surveillance. These will be presented on the MUSIC registry dashboard, and both urology practices and individual urologists can use these data to understand and improve performance in this area. Taken together, these steps will facilitate our continued efforts to make Michigan the best place in the world for prostate cancer care.